Welcome back, everyone. We are going to move on now to baseline measures, which is generally the first thing that we do after defining our cohort. And I was kind of thinking, as Christy was talking, how funny it is that she had taken a little bit of extra time. We should have thought of that to begin with, because one of the first things that I do when I'm starting to work with a new investigator that's interested in SEER-Medicare data is try to manage their expectations and say, the cohort definition is complicated, it's complex, and it takes a long time. It takes a lot longer than you'd think. You would think that, the treatments are going to be really hard to define, but really getting a well-defined cohort is something that takes a lot of finagling. You have to kind of go back and forth and think about things and maybe measure things two different ways and look at how it is. So it's really an iterative process. So now we're going to talk about understanding that cohort that you've defined. And oftentimes the first thing we do is try to look at baseline characteristics because we want to understand how the cohort compares. We have our treatment and comparison groups. We want to look at how they compare at baseline, maybe decide how to handle differences between the groups. Do we need to do matching, look at propensity scores, stratification? And as I mentioned, this may be an iterative process. Once you've kind of got your baseline characteristics, you may find out things about your cohort where you're like, oh, actually, I didn't know there were going to be so many 85-plus-year-olds, and now that I think about it, the treatment that I'm looking at isn't relevant to them. Maybe I'll go back and remove them from my cohort of interest. So it's something that you may need to revisit and then go back and do your baseline measures again. So throughout this presentation, we're going to be talking about an example from my past. We were looking at prostate cancer treatments. I thought it was a good example because in this particular paper, we were looking at pretty much the gamut of local treatments for prostate cancer. And we also included a control group because what we were looking for were urinary adverse events for men who received prostate cancer treatment, and especially interested in how they changed depending on treatment group. For example, radical prostatectomy often has adverse events kind of soon after the surgery, but we were expecting to find that radiation would kind of have more chronic adverse events. So we'll be talking about kind of our results in the segment 5, I believe, in the outcome segment. But for this, we're just going to be talking about how we defined our cohort, how some of the common things that we measure to create our Table 1 show up in the data, and why we might be interested in them. So most baseline measures that we use are found in the PEDSF file. That's that Patient Entitlement and Diagnosis Summary file. That's where every SEER case shows up, and we'll have one line per case, and if they have multiple cancers, then each cancer will show up on that same one line. Things that we usually measure from the PEDSF, the patient's age at diagnosis, oftentimes their race, sex, registry, any other geography of interest, whether it's health service areas or urban-rural differences. We look at cancer diagnosis information. So we'll be talking about each of these in turn. Other information that we may include in our Table 1 may need to be found in other files and sometimes summarized and then linked back to our PEDSF or our cases. So comorbidity measures usually are summarized from the claims data because in general, we're measuring them based on the diagnosis codes that are found in the claims. SEER registries do not collect information on comorbid conditions. Other information that's usually linked, census tract or zip code level variables, there is a separate file for census tract level variables, which can be linked to the PEDSF using census tract code. And then there's information for non-cancer controls. That's found in the summarized denominator file or the sumdenom file. So we don't have any cancer information on them, obviously, but we will have some of the other demographic information and also their Medicare enrollment that we can use, again, to create that cohort. So age at diagnosis is something that we often measure. We're usually interested in it. Here's just an example of how prostate cancer differs from testicular cancer. And perhaps this is a better slide for, for defining your cohort, but if you look at this, the median age for prostate cancer diagnosis is 67 years. So over half of the cases will show up in the Medicare population, the elderly Medicare population, whereas for testicular cancer, the median age at diagnosis is 33 years. So if you had already done your cohort definition and then went to summarize your age at diagnosis, you would find that you would probably have lost a lot of patients if you were looking at SEER-Medicare data for testicular cancer, and you would have very few people in the elderly categories. We also wanted to look at female breast versus ovarian cancer, and this actually surprised us a little bit. We were thinking that ovarian cancer cases would be relatively younger, but actually they're about the same. So if you were looking at both of these, you would find over half of the populations in the Medicare data, or I should say just under half of the population in the SEER-Medicare data, because the median age at diagnosis are 61 years and 62 years. So for our population, one of the reasons that you may want to include age in your treatment group descriptions, what we found is that increased age may reduce the likelihood of surgical procedures. So we find that our radical prostatectomy patients, 51% of those are ages 65 to 69. It's relatively less common for older patients to receive radical prostatectomy. On the other hand, for our external beam radiotherapy patients, at least 13% were even in the 80 to 84 age group. So that's a treatment that can be used at older ages with less complications. Race and ethnicity is also something that we often want to measure. There are several race variables available in the PEDSF. I'm going to highlight a few of them. And also note that there are variables that come both from the Medicare side. You'll find in the PEDSF it will say the source is the EDB. That's the enrollment database for Medicare. It is race and ethnicity are included in one variable, mutually exclusive groups. So you can see that there's white, black, Asian, Hispanic, North American Native, and unknown and other. But note that Hispanic is included within that. So even though Hispanic is an ethnicity, it's included there. So you can't both be white and Hispanic in the Medicare data, which tends to lead to relatively lower rates of Hispanic cases. The other thing to note is that if you're looking far back in the data, Asian Pacific Islander, Hispanic, North American Native, that was added first in 1994. So if you're looking farther back in the data, you are really limited to white, black, other, and unknown. There was also an attempt, there's an RTI race variable that uses Hispanic surname matching algorithm, and that was an attempt to try to tease out among the people with the Medicare race of white or black if they also have a Hispanic ethnicity. So it basically looked at their last name and tried to, and some other information, and tried to look at the probability that they would be Hispanic and then assigned based on that. RTI is the Research Triangle Institute, if you're wondering what that means. But some of the groundwork for this was actually done by Dr. Beth Fernig, who you just heard from. There are also SEER variables. So these are reported by the registries, and there are a few of these. There's a race recode Y, race recode A, race and ethnicity, but then they also have separate origin and Hispanic origin variables. So they do separate ethnicity from race. You can use the two variables in conjunction to create your race codes for your cohort. I just wanted to show you kind of how they differ. For Medicare versus SEER, the blue bar is from the Medicare race variable, the EDB variable. The gray bar is SEER race combined with the NHIA origin variable. So I took two variables and used that to define the race categories and make them similar to what the Medicare had reported. And then looking at what the RTI flag looks like. And I want to note, I'm limiting this from 2007 to 2014 because the RTI flag is available as part of the Part D denominator, and it starts in 2007. So what we find is that the with the EDB variables, the non-Hispanic white population is relatively greater than using SEER or the RTI flag. And you can see that the number of Hispanics, the percent of Hispanic cases is much lower. And again, that's because of those mutually exclusive categories. Someone can't be both. And I should say, I say non-Hispanic white as the category here, but that really just means that's how it shows up in the data, not necessarily that they are non-Hispanic white. They could be both white and Hispanic. But for SEER and RTI, these would be the non-Hispanic white. And one of the reasons that we're interested in measuring race and ethnicity is that sometimes there are systematic differences in treatment groups by race. Now, for our study, because it included a control population, we were limited to using Medicare race, which obviously is not ideal because the Hispanic population is relatively low here. But because we wanted to keep the comparison similar across groups, we used the Medicare race because anything that comes from the SEER side is not available. And our data did include cases prior to 2007. But we see systematic differences in the treatments by race. So this is not a new finding for us, but we did find that Black men were less likely to receive radical prostatectomy. They were more likely to receive external beam radiation therapy. So we have like 10% under external beam radiotherapy versus 6.5% for radical prostatectomy. So it's something that's known, and that's why we felt it was important to include that in our analysis. Socioeconomic status, people often want to know how well off people are, because that may determine the ability to pay for treatment, to access treatment. We are limited to zip code or census tract level variables for this. We don't have individual household income or education levels. So we rely on the zip code or census tract level. And that still tells you something, right? It tells you where they live, how's everybody around them doing. And it's a pretty good indicator. The data are derived from the decennial census or the American Community Survey. So the decennial census is obviously every 10 years. The American Community Survey is fielded more often, and you can find links to both of those, so you may want to choose between those depending on when your cases are defined from. The variables are generally continuous, so median income is a continuous variable, percent with high school education is continuous, and you can even find age and race specific, so you can say within this zip code, everybody over 65, what is the percent of high school education? In our case, we just used the standard median income for the zip code and high school completion. We used a zip code level. At the zip code level, about 5% are missing socioeconomic information. We excluded them here. We excluded them from our entire cohort. And we broke them, even though they are reported continuously, we broke them up into quartiles. And why we did that, you do see that there are differences between treatments for depending on the average or the median income from where people live. So people with the lowest median income were less likely to have brachytherapy and EBRT combined. You can see that people with the highest income were much more likely to have brachytherapy. So and then education has similar patterns. So you can see that we just felt like that was important for understanding, the treatment groups that people found themselves in, and then subsequently for their outcomes. There are other person-level variables that give you some socioeconomic information. For example, there is Medicaid enrollment. People end up enrolled in Medicaid often because they have lower resources. Partial duals, so we call people who are enrolled in both Medicare and Medicaid, we call them dually enrolled, and I will refer to them as duals. The partial duals receive Medicare premium and copayment support. They generally have slightly higher resources where they don't qualify for full Medicaid benefits, but the state may pay their Medicare premiums for them and pay their Medicare copayments. And the reason for that, of course, is so that the state Medicaid program doesn't have to pay for all of their care, but it will help them get care through Medicare. That's relatively less expensive for the states. Full duals will receive Medicare premium and copayment support, but also receive full Medicaid benefits as well, so things that are available to Medicaid enrollees that wouldn't be available to Medicare enrollees. There are a couple of variables that you can look at. A state buy-in variable is available in all years, but note that if you are used to using Medicare data, you will find that it's formatted differently, so I would encourage you to look at the codebook carefully. Codes 1, 2, and 3 indicate the receipt of some support. I would like to also note that this is not a really good measure of poverty. If someone qualifies for Medicaid or for premium support, they tend to have fewer resources, but not everybody with few resources does receive assistance from Medicaid. So it's, sensitive but not specific, or specific but not sensitive, I should say. And then there's also a variable for dual enrollment. So again, tells whether they're dually enrolled in Medicaid and Medicare. It's available from 2007 plus in the Part D denominator file. So anybody that's enrolled in Part D will show up in that Part D denominator file, and you'll have information there. So geography is also usually of interest for people. What registry people arise in, also health service area. That's something that's externally created by the National Center for Health Statistics, and it's centered around hospital care. So, everybody in a certain area they all tend to use the same hospitals, and so we'll group them together. We expect them to sort of be treated similarly, or at least, have the same external effects on their treatment choices. There's also an NCI modified health services area, and that is where all counties in one HSA are from one state or SEER registry and/or SEER registry. So you'll see relatively more categories for NCI modified health service area, but it's helpful when you're looking at the SEER program because then you can divide by registry. There are also variables to define how rural a beneficiary's residence is, and we'll talk about that a little bit on the next slide. And then I just wanted to note that you can get zip code of residence, but it's restricted variable. So you have to, when you are applying for the data, justify why you need to use it. It's often used to measure distance traveled to treatment or for other linking to other sources. So just to note that it's available, but it does not automatically come with the data. So if you're interested in looking at care in rural versus urban areas, you may expect it to be different based on how far someone has to travel for care. The rural-urban commuting areas is a 4-level variable defined in both 2000 and 2010, and it tells you kind of, everybody that's in this RUCA travels to the same center. So you can see, if someone is traveling farther to get to a city center, for example, so it's generally commuting patterns. There's also an urban-rural indicator that's 4 levels that again is defined in 2000 to 2010. And I have the most experience with the rural-urban continuum. It's defined by the USDA, the U.S. Department of Agriculture. It's a 9-level variable. It's based on the county of residence, and it will say, whether that county has a big metro component to it, or whether it's a very small population center. It has a very small population center, and it's also not even adjacent to a large area. So you can kind of, things run the gamut from big metro to rural, non-adjacent county. Comorbidity is also something that is often measured in relation to defining your treatment groups or understanding your treatment groups. So comorbidity is additional diseases beyond the condition under study. It's akin to multimorbidity, which is any occurrence of multiple coexisting conditions. Generally, it predicts mortality, and we'll talk more in depth about that. And it can impact treatment choices, whether or not there are complications, the relative costs of care increase for people with more comorbidities. The Charlson Comorbidity Index is most often used with the SEER-Medicare data, partially because there's an algorithm available on the SEER-Medicare website. It was developed in 1987 using medical records, but there have been multiple updates. The summary measure, so it's a summary measure, it's a single score that's derived from 19 specific medical conditions, which will be described later. Each is assigned a weight between 1 and 6, and the weight that it's assigned is based on how likely it was to cause mortality within 1 year. And it was originally developed in hospitalized patients, but as I mentioned, there have been multiple updates over time, so it has grown to include information from not just hospitals, but also other claims data. So there are multiple iterations over time. And you can find this information on the SEER-Medicare website. There are 2 different versions of the macro that's available to run the algorithm. There's one from 2000 and one from 2014. And the one from 2014 has some differences. They have a table you can kind of look at. It removes some of the procedure codes, so you can take a look at some of the differences there. So Charlson Comorbidity, when we look in the claims, we often use a 1-year look back. Remember, Christy said you may, as you're defining your cohort, you may require Medicare enrollment for 1 year prior because you want to look at their claims, and you don't want to include people that you can't possibly observe their claims because they weren't enrolled. So usually you're going to need to limit your cohort to age 66 plus in order to capture those 12 months of the full 12 months of enrollment. You may choose to not include month of diagnosis in it, and we're going to talk about that in a minute. Oftentimes that peri-diagnostic period involves a lot of workup, diagnostic workup, and sometimes conditions are found in that period. And so you'll see differences whether or not you include it, and we'll talk about that in a second. The theoretical range of the Charlson Comorbidity score is 0 to 23. So 0 if they don't have any of the conditions, and if they had every possible condition, it would be they would have a score of 23. The actual range that we find is from 0 to 9. So when we talk about whether or not you want to include the month of diagnosis, and I believe in the macro, it's pretty easy. It gives you the option of including month of diagnosis. You kind of get to define what your period is. Do you want to include the month of diagnosis? So here is just, if we look at all cases, you can see that if you don't include the month of diagnosis, if you look the 12 months prior, but not including the month of diagnosis, that the number of cases with 0 comorbidities is higher. And if you do include it, then the number of cases with 0 comorbidities is lower, and you have a bit more of a distribution and a tail of people that have 6 comorbidities or more. This varies with cancer diagnosis. So you can see for breast cancer, there's a relatively smaller difference, but for colorectal cancer, there's quite a lot larger difference. And some of that is, from, screening. Some of that is from risk factors for the cancer. Will depend on how often people have already been diagnosed with their comorbidities. So I would say you can take a look. You can run your macro both ways. You can try to decide how you would like to do it. Now, again, this is something that is calculated from the claims. It's not something that appears on the enrollment data. So you can run a comorbidity macro simply using the MedPAR file, the hospitalization claims. That was originally how the Charlson was designed. But the SEER Medicare data we have more information than just hospitalizations. We have information from physicians and outpatient facilities. And so the macro you can also include both of that information as well. And in general, it will say, you have to have at least 1 diagnosis from a hospital or 2 or more diagnoses on different days from a physician's office or an outpatient setting for us to be pretty sure that they have the comorbidity, and those flags are created within that macro. And then the macro will roll it up to the patient level, and then you can then get that at the patient level for your table. What are the conditions that are included in the Charlson? You can see them here. Anything from myocardial infarction, which is a heart attack, to diabetes, chronic obstructive pulmonary disorder, that's COPD. You can see the weights in parentheses here. Anything that doesn't have the weight next to it has a weight of 1. There has been some talk recently about the AIDS, including the AIDS with a weight of 6 in the Charlson, because AIDS actually has a relatively better prognosis than it used to, but that's something that you can look into the literature on. Right now, the standard macro does still include it with a weight of 6. The original Charlson does include metastatic solid tumor with a weight of 6. This is not included in the SEER-Medicare algorithm. Oftentimes, we want to include that. If we're interested in metastases, we want to include it separately, not necessarily within the comorbid conditions. So it's just not included in the SEER-Medicare algorithm. Generally, comorbidity does impact the treatments that people receive. It will impact their outcomes. For our prostate cancer cohort, we find that people with fewer comorbidities are more likely to, or I should say people with radical prostatectomy are more likely to have 0 comorbidities than other groups. So the external beam radiation therapy patients tend to have more comorbidities, and the group with the most comorbidities is actually the cryotherapy group over here. Almost less than half, or about half of them have Charlson score of 0, but there are quite a few that do not, that also have other comorbidities. But just to remember that comorbidity measures rely on reporting of conditions in the health claims. So this is not information that's reported by or collected by registries. So that's one strength of the SEER-Medicare data, is that you are able to get that information on comorbidities. However, anything that's underdiagnosed, that maybe the patient has it, but they've never been officially diagnosed by a healthcare practitioner, or it's something that maybe they were diagnosed with, but it hasn't necessarily been reported on their claims because it's not necessary for payment, or it may fall off because other conditions are more important, and so they just don't show up. So hypertension, osteoporosis, diabetes, all tend to be underreported on claims, even though there's evidence that the patient has it. Conditions that may not be recognized or reported until they lead to problems, it doesn't mean that the beneficiary, the patient that we're looking at, does not actually have it. It just means that there was no reason to report it, or it wasn't recognized until they've had a problem. So, for example, the osteoporosis might be first noted on a fracture claim, but I think that most of us would think, oh, they probably had it prior to their fracture, right? And so this is a general, as we're looking at using claims to define treatments or anything, inference, and as we look at, defining our outcomes, inference is really going to be affected by the timing of claims report. Because osteoporosis is not well reported, you can see that people with poorer bone density may be more likely to be treated with bisphosphonates, but maybe they don't have that diagnosis code. And so you might get the conclusion that bisphosphonates cause fractures, when in reality they were taking them because of their poor bone density, and then they had a fracture because of their poor bone density. You have to really think through how you are going to, what you're going to believe from the data. Another hot topic with chemotherapy was looking at chemobrain or cognitive impairment that's caused by chemotherapy. But dementia and cognitive impairment, it might not be formally diagnosed or coded, but it could actually influence the decisions for treatment. And so how would that show up? If you had a finding that chemotherapy protects against dementia, so people that have chemotherapy have relatively lower rates of dementia later, does that make sense? Or could it be that the people that were having more cognitive impairment ended up not receiving the chemotherapy? The other thing that we often include when we're looking at differences in our treatment groups are cancer characteristics. So these may affect the treatments that were recommended to the patient, will impact the treatments that are actually used. With our prostate cancer, we have clinical T-stage, we have the WHO grade, and I just want to note, of course, for our controls, we don't have any cancer information because these are non-cancer controls. So we do find that brachytherapy is used, is more often used for patients with lower stage disease, and then you can see just differences. And there are some unknowns. There will be people who we don't have stage information on. So you'll have to decide, again, as Christy had mentioned before, also how you want to. Do you want to include them? Do you want to exclude them because you don't know? So I would just make sure you take a look at that and whether it, whether that differs by treatment group. Some cancer-specific measures that we have in the data, we have cancer stage and extent of disease. That has changed over time. They do have a historic stage that will give you whether it's a localized disease, regional disease, or distant disease. But for each specific cancer, there are a variety of cancer-specific staging information. So for the extent of disease, it will tell you for prostate cancer whether it's inside or outside the prostate capsule, whether it's within the pelvis, or whether there are bone metastases. So you get quite a lot of information for specific cancers. For cancers where the size of the tumor influences staging, then you'll get information on tumor size. You also get information on lymph nodes. You get information on whether or not lymph nodes were tested, and then you also get information on if they were tested, were there any positive nodes, how many nodes were found, how many nodes were tested. And then you also have information on the grade of the disease. So if there was a biopsy, how well differentiated are the tumor cells. You also have some other very specific information. So for prostate cancer, the Gleason score is akin to the grade, and that is reported for prostate cancer. You also get PSA blood testing values. For breast cancer and ovarian cancer, you have the BRCA information. In general, so SEER registries do not collect genetic characteristics. There is some information. They have developed a relationship so you can get some information about oncotype results, but you do not collect information on family history, surgical margins, behavioral risk factors. These are all things that may be important for your study. If they are, you're going to have to try to figure out, is this the best data for you? Now, SEER doesn't collect information on behavioral risk factors and family history. There are some diagnosis codes that might lead you to believe they will show up in the claims. Smoking, obesity, alcohol use, family history of cancer. Beth mentioned these before. So the codes exist, but if you see really, really low rates of smoking among lung cancer cases, do you believe it? Would you say that most lung cancer cases are from non-smokers? Probably not. Obesity it can be reported in the claims. It's required for bariatric surgery. So you'll see it if it's kind of related to a treatment that a patient is receiving, but it's rarely coded otherwise. So you have to really ask yourself, is it essential to my study? Can I get by without it? You certainly have to say maybe in the limitations that it just was not available if you decided to go forward. But if it is essential, then you might need to look at a different source of data. So when we're looking at our covariates, we have to think about where we're going to find the information. The demographic information is often available on the PEDSF. And the summed-denom file if you have a control population. Clinical information can be gleaned from the PEDSF and also from the claims, like comorbidity measures. And then you just have to think, can you find the information? So for lifestyle and behavioral risk factors, understanding what does appear and what doesn't appear in the claims is important. So I think that's all, and we have some time for questions.
Yeah, we do have a number of questions. We'll just take a few before we pause and go for the final segment before lunch. So one of the questions that came up was whether or not a researcher could consider using the CCW chronic conditions file, or whether they should focus on creating their own comorbidity measure. What are some of the pros and cons?
Yeah, so the Chronic Conditions Warehouse, I didn't mention that, did develop some algorithms, and you can actually find them on ccwdata.org. You can find the algorithms that they used to flag chronic conditions, and they also tell you whether or not someone was enrolled, whether they were both enrolled during the period and you found a chronic condition, or whether they weren't enrolled and that's maybe why you are not finding it. The one thing I would caution you on is that you may want to take a look at the algorithms and really figure out whether or not, and that this is true of the Charlson Comorbidity as well, you know, I would recommend looking at it and seeing if it's actually measuring what you want it to measure. The CCW data are updated for ICD-10, so that's one consideration, that the Charlson macro is not. But it's, you know, it was, when it was updated for ICD-10, it was more of a crosswalk update. They're still working on getting everything validated, but it's something that you can use. The CCW file will give you individual conditions, and so I've never used that to try to, you know, flag the individual conditions and put those into a Charlson Comorbidity score. I don't know if that would be possible, but.
And just as a follow-up, where would researchers find information about the SAS macro?
Yeah, on the SEER-Medicare website, I often will just search for SEER-Medicare Charlson macro, and that will get you there. But if you look around on the SEER-Medicare website, I think for the resources available to researchers is the tab you want to look under.
And it's a downloadable file. Another question that came in was, what are some considerations when researchers are trying to select between the different race and ethnicity variables within the data?
Yeah, so I would take a look at the variables. SEER does have some recommendations in terms of using race variables. I think right now the site or the race recode Y is the preferred variable to use in terms of the accuracy. However, I would take a look at the actual variables and see if they have the categories that I'm interested in. Because they're available on the same file, you can cross-tab them and look at the differences, see what you think. You can compare them maybe to census information for the areas of interest. You know, if you're looking at a specific subpopulation that you're really interested in, use your information based on that population to see if you know, which one you feel the most comfortable with.
Okay. Well, with that, I think we're going to take a quick 5-minute break to switch over. So we'll return at 11:05 Central Time and begin discussing cancer-directed treatment.